Good morning to everybody and welcome to today's presentation. We're fortunate today to have Dr. Brett van Staden. He is an experienced emergency medicine doctor. He studied at WITS University and completed his internships at Groote Schuur Hospital in Cape Town. During his community service in Limpopo, he focused on emergency and family medicine. Since 2023, he has been practicing at Mediclinic Midstream Emergency Centre, where he provides expert emergency care. He completed his diploma in primary emergency care in 2024. Thank you so much.
Thanks very much. Thanks very much for having us and always organizing this. So today I'm going to be going through a basic approach to toxidromes and QT poison patients. I chose this topic because in the last few years, this has generally been some of the more complicated cases I've seen, the ones where you're left kind of scratching your head because you're not sure what's going on. Even once you've sent the patient somewhere, you still sometimes don't know what's going on, but you can at least stabilize them and get them through to find the answers later. So everything always starts, as we know, with our ABCs. But also for any sort of poison patients, personal protection is going to be important. If there is sort of anything on the patient, any sort of contaminants, you want to try and get it off of them, clean the patient because it's both protective to you and your staff working in the units, as well as to prevent further contamination for the patient. Then afterwards, if you do good ACLS approach with focusing on your ABCs, good airway, good breathing, good circulation, I think you can manage pretty much 80 to 90% of any patient that comes through. And then we'll learn a little bit about the specific antidotes and specific treatments for some of the cases. But essentially, in the most cases, it's supportive care, making sure that you stabilize the patients, and then it'll give you time to figure out the next step. Other supportive adjuncts that you can add, it's your bloods, ECGs, generally just a full blood count, a UNE, and your electrolytes. There is in cases a creatinine kinase, but I'll chat about that a little bit more later. It's only really for certain cases, and it's not for every patient that you should be doing it. The ECG, often you'll just be having a bradycardia or a tachycardia, depending on the drug. If you are starting to see QRS or QT changes or any sort of arrhythmias, you're probably looking at a more toxic dose. So be a bit more aware. If you are seeing ECG changes, then be a bit more alert. A blood gas is always going to be helpful. The anion gap, we'll chat about it now. The high anion gap kind of can point us in the direction of what sort of drug we've taken. And also for the respiratory efforts, just show us a picture of where we're at with the patients, especially if they have a bit of a decreased GCS or if they've got any sort of respiratory compromise, just to see where we're at. And never ever forget glucose. That's always one that we need to never forget. So this is just with the anagram for our high anion gap metabolic acidosis. To calculate it, it's our sodium plus potassium minus your chloride plus your bicarb. The high anion gap is anywhere above 12 to 16. It's 12 if you don't use the potassium in your calculation. It's 16 if you do use potassium in your calculation. They say it's not really necessary to use potassium for that anion gap. So just your sodium minus your chloride and bicarb. There's a whole bunch there, but some of the common ones that we might see is the paracetamol and the iron tablets, the aspirin potentially. You can just kind of think about it. If you do work out, you have a high anion gap, think about the mnemonic, try and find if there's something in here that you can think of, and then take it from there. So often with these patients, they'll be brought in by the EMS saying we were called to the patient who was unresponsive. Sometimes they'll have medicine packets next to them, sometimes they won't. Sometimes they'll bring families, sometimes they'll have a collateral history, but often you might just find the EMS said, we got a call for this patient and we're bringing them to you. If you can, try and see if you can get some sort of contact history. Sometimes the patients have their phones on them. See if you can find an emergency contact. See if there's any into your unit before, if you've got any family history or any sort of other person that can help you. The EMS, you can ask them anything that you can about this, where they found them, if they've given anything on the scene, and if they brought the medications with them. An important thing is to know why the patient has access to the drugs that they took. Is this just something that they were prescribed acutely and they may be mistakenly overdosed? Or is this something that they've had chronic use to and chronic dependence on, and now this is an intentional overdose? Because for some of the drugs later, chronic use can make it a bit more challenging when managing the patients. Just be aware. Sometimes there is just you can have co-ingestions. So even if the paramedics or the family say, oh no, they just took this tablet, they just took that tablet, always need to be concerned about something else. Where you can, the weight-based dosages to figure out if it's a toxic or a lethal dose is going to be important, because if you find that the patient only took 2 or 3 tablets of something and it's not actually going to have any toxic effects, it's better not to now throw nasogastric tubes down their throats and give them activated charcoal unless it's actually going to be doing some harm. Urine drug screens can be helpful, more just to confirm, but it's not really going to come out in time for you to start managing the patients. So it's more just you can send one off and then see what comes up later. Psychological support, I think, is going to be important pretty much for anybody that comes through with some sort of toxidrome or overdose. Whether it was an intentional overdose, it's an easy one, then you know they're going to need some psychiatric and psychological support going forward. But also, if now a patient didn't know what happened, they woke up in the hospital, can also be traumatizing. So please do just consider that when they are on their discharge. And then just to note, if you do have a drug that's confirmed, you know the weight of the patient and you know the amount of the, you can call the Aflatox poison center, the 24-hour line. Somebody there who has a database. Sorry, I think somebody's mic is on. Okay, thank you. It's turned off.
Turned off now.
Yeah. So you can call the Aflatox Poison Center. Once you know the drug, they'll be able to look through their database, see what sort of toxic effects and lethal effects at the dosage that you calculated. They can provide you on some guidance further and any specific antidotes or treatments that they would expect, or the monitoring plan for them going forward. So once the patient comes through to you, you've done your initial, you've seen, and you started with your ABCs. A good place to start, if you don't know what's going on, is just to start treating what's in front of you. So general supportive care. If they're hypertensive, they say we can be quite aggressive with our fluids. You can go up to 2 liters of isotonic fluids and go to vasopressors sooner, just because generally the vasoconstriction is more what's needed for them than inotropic supports. If there's any seizures or agitation, benzodiazepines are going to be your best friend, both for your safety, the patient's safety, and any staff. Just with regards to ECG changes, this is just one of the more interesting ones that you can see is if you do get this prominent R wave in AVR, and you start getting a bit of QRS widening, you can consider a TCA overdose. There's not many other identifying ECG changes that I could see. This was just one of the interesting ones that I found. If you do start seeing QRS widening or a VTAC, consider sodium bicarb as part of your ACLS protocol steps, just because that can help prevent any further changes. With the toxidromes and acute intoxications, you can have a prolonged resuscitation. There have been cases at up to 60 minutes, you still had a good outcome with the resus for young patients with no comorbidities. So obviously it's patient dependent, but you can, in the back of your mind, prolong your resus if you find that is necessary. So our first toxidromes, opioids. Generally, it's quite a typical one. They come through, they in a bit of a coma, decreased consciousness with these small pinpoint pupils, shallow breathing with potential choking or gurgling sounds if they've aspirated or if they're not maintaining their airway. can have some hypothermia or cyanosis peripherally as well. We've got quite a variety of opioids available. They've all got different half-lives, metabolisms, and severity. Something that I learned, loperamide is technically an opioid, and if you overdose on it, it loses its specificity for the gut. So you can actually get a toxidrome from loperamide overdose. This is where the previous use is quite important. If a patient is a chronic opioid user, managing it later with it, it's going to be a little bit more careful. And also the dosage that they used to overdose is probably quite a bit higher. Airway is going to be our main thing that we're concerned about with opioids. They found that if there's an end-tidal CO2 more than 50 millimeters, then there are expected complications if you don't do anything to intervene with the airway. So when we get to that point, if they are maintaining their airway, naloxone is going to be the antidotes. But again, it's not your first drug that you jump to with opioids. You still do your good ACLS principles. Once everything else is settled, then you can start considering naloxone. If they're in cardiac arrest in an opioid overdose, you start at 2 milligrams of naloxone. If they're pending respiratory arrest, you can start at 0.4 or 1 vial up to 2 milligrams. You repeat every 2 to 3 minutes. If you get to 10 milligrams of naloxone and you aren't having any luck, you're not looking at an opioid overdose. Then you need to think of something else. When we're giving naloxone, we're not giving it to wake the patient up. We're giving it just to get their respiratory rate up to 12 or to get the end-tidal CO2 down and to maintain their airway. And once you've given it and you want to start an infusion just to maintain it, because the half-life of the opioids are generally much longer than naloxone, you can take 1 vial of naloxone, put it into 9 mils of saline, and you give it at a 1 to 2 ml dose titrated to effect. They are making more interesting ways of giving naloxone. These are some of the intranasal devices that I think, especially in America now where it's an epidemic, police and emergency response services are carrying it. I think we do have it, but some of the EMS actually just have the atomizer. Alternatively, naloxone can be given through any routes, subcutaneous, intravenous, intramuscular, intraosseous even, but those are generally all your pre-hospital routes. IV is our one. We don't want to give it anywhere else because it's predictable when you give it through an IV, but just to note that it can be given through various different routes. Sedatives and hypnotics. This one is going to be mainly just supportive for the patient. The airway can potentially be a complication depending on how much and the co-ingestions with this. We're seeing this quite a lot where people are struggling with sleep, struggling with depression, and a lot of the times they're taking it because as a suicide attempt, so they'll just tell us, no, I just wanted to sleep just to make things go away for a little bit. So please think about the psychological support once they do wake up. See if they need a counselor before discharge or if it is just as an outpatient review. Mild to moderates, if they only took a few, you're going to get a bit of sedation and some poor muscle coordination. The severe is the patient that comes through. They describe them as a coma with normal vital signs. The patient generally has a GCS of potentially up to 3, but their vitals are all stable. Respiratory rates fine. Sats are sitting at 97. Can happen with this. Though the higher doses, you can then still progress to a hypotension or respiratory depression. And if the patient took these and then decided to go outside or had the windows open, not under blankets, and was left for a few hours, hypothermia can be of a concern. And this is where the creatinine kinase might come into play. If the patient was unconscious or the EMS found them with an unknown time frame, you can think about it, just to look at it, just in case it can potentially go to renal failure if you do miss it and we aren't aggressive with the fluids. There can be a concern for an aspiration with them because they sometimes can't protect the airway or if they couldn't clear the secretions. So just be out on the lookout for that. It's supportive. Again, just look for the CO2 retention if they've got respiration. We do intubate if they've got severe respiratory depression. Here's the potential for the Rhabdo, as I said. And then flumazenil, can chat about it. There's a slide at the end that I've got questions that I found. Some people are saying it's contentious. Some people like to use it. Some people don't like to use it. But if you are going to use it, just chat with your specialist and get their opinion if they are the ones to prefer to use it or not. Start at 0.1 milligrams IV, repeat every minute to the desired effect up to a maximum of 1 milligram. And then every 20 minutes, you can go to that same dose, so a total of 3 milligrams per hour to reverse the effects. It does work well. I had a patient the other day, GCS was about 4 or 5. Left the room, we prescribed it. I went back just to go and find something, and the patient was sitting up and scratching her head, and she was saying, so what's happening? What's going on? So it does work, but yeah, I'll chat a little bit about later as to why it's potentially contentious and what we just think about when we do use it. And now the old adage of GCS 8, do we intubate straight away or not? This is one of the cases where we potentially now have the capacity to manage conservatively rather than going straight away to intubating. So this is just a bit of an algorithm from up to date as to if we have to jump into intubating a patient straight away or not. So are they failing to maintain their airway? Yes, that's an easy answer. Are they failing to oxygenate or ventilate? No. Then are they expected to change? No, this is where we can observe. So this is for your short-acting sedatives such as ethanol, or some cases the sedative hypnotics. You can put in a nasopharyngeal airway potentially if you want. But yeah, they're just finding that the GCS was for traumatic brain injuries. So with these, they've done a study and found that conservative management, where there was buy-in from the specialists, from the nursing staff who are going to manage him. If you can watch the end-tidal CO2, if they're maintaining their saturation and their respiratory rate and they're not expected to change, we can potentially just manage them conservatively, but there is always the potential that if things change, we would then need to intubate later. But yeah, just something to think about. But yeah, if they're not maintaining their airway, definitely don't say, no, we don't have to intubate them because we said so. If they're not oxygenating and ventilating, you do need to still manage the airway. Our anticholinergics. This is the fun, blind as a bat, mad as a hatter, red as a beet, dry as a bone, hot as a desert. So it's an inhibition of your acetylcholine to your muscarinic receptors. There's over 600 medications that have an anticholinergic response, our main ones being your antihistamines, hyoscine or buscopan, and then some of our antipsychotics. Whenever you Google anticholinergic toxidrome, you're always going to be brought up with 3 plants, and I'll show you them next. I don't know why they come up, but they do come up. I've never seen one myself, but they're always there. So they get this agitation or delirium. They get these dilated pupils. They're very flushed and hot. They get a tachycardia, which is one of the first signs. Absent bowel sounds, also with urinary retention. Some of them also say there's full as a flask. It's one of the others. And yeah, hypothermia as well. Generally, most people, when they have this, they do very well. You just need to recognize it when you see it and manage the symptoms, and they do quite well. They do describe an antidote, the physostigmine. I don't think it's readily available in South Africa. I couldn't find any evidence about that. So generally, we're just going to be managing supportively. These are the 3 drugs, the 3 plants, sorry. Jimson weed. It's quite a common weed apparently in South Africa. And of note, we get 2 very important drugs from 2 of these plants. I'm sure we can see from the Atropo belladonna, we're going to get atropine from that one. So that's where they first synthesized atropine from. The nightshade, they do make jam out of a very similar nightshade in KZN. They say there's red and purple berries rather than black. I tried to find images to compare them. They all look the same to me. So I think that's why people maybe eat the wrong one, you know.
Well, I think they're masterful jam.
Yeah, exactly. The Jimson weed, we get hyoscine or buscopan from that as well. And the amanita, that's also just if people are foraging, they can try their luck. There is another one, another amanita, which is the death cap, which is a much worse drug than this, or much worse fungus than this. So please don't eat mushrooms if you find them out in the open. So our cholinergics, most likely our organophosphates. We do see these fairly often, especially in Brits. Apparently it's getting there a little bit more. It's an inhibitor of acetylcholinesterase, which then just causes an excessive stimulation of your muscarinic or nicotinic signs. The typical muscarinic ones is the sludge and the dumbbells, where there's just secretions coming from every orifice, your diarrhea, urination, bronchospasms, bronchorrhea, emesis, lacrimation, sweating, and salivation. Nowadays, some of the organophosphates are more synthetic and they're not giving us this typical muscarinic sign. We're getting actually more of the nicotinic signs, or we're getting a delayed onset. So some people are now coming through, they're saying they took something, starting to managing them, and before they get through towards, then you're starting with secretions and other symptoms. We can do cholinesterase levels, but the lab time is quite long. So again, it's more something that you would do when you see the patient, just to confirm your diagnosis once they get through. This is where your PPE is quite important, because contact through the skin can transmit it. So again, watch your patient, clean the patient off, don the proper PPE. Once you diagnose it, airway is going to be very important for them because of the bronchorrhea. So intubating them early is quite important. And atropine is going to be our antidote of choice for them. You start at 1 milligram, you double it every 5 minutes, going until you have cessation of your bronchorrhea. We aren't targeting many other things. It's not just the bronchorrhea. And that will give us a sign as to when we've gotten the right dose. Some people we've had internship days went up to 64 milligrams of the atropine. So one person's job was literally just to crack vials in the 5 minutes before the next. Yeah. Once you have your total dose, you calculate the infusion as 10 to 20% per hour titrated to the effect again. But you take every milligram that you've given up to that point. Your total dose isn't your final dose. It's the total amount you've given up to that point. And then there's another medication that's the pralidoxime or obidoxime, which again, I don't think it's readily available. I'm not sure if I've seen it, but this one you can use in addition to the atropine. It's not used instead of. It has to be used with the atropine. But mainly if you're giving the atropine, the obidoxime and pralidoxime is not going to be too important. So yeah, the early airway interventions necessary for them. The atropine is targeting the bronchorrhea, and then they found that the organophosphates are getting these neurological symptoms in the next, or it's a bit of a delayed effect. So in the first 1 to 4 days, they can have a worsening of the muscle weakness or cranial nerve weakness. They get these decreased deep tendon reflexes and can again have some respiratory insufficiency. And then at about 1 to 3 weeks, they identified the chlorpyrifos, which was a pesticide that was quite widely used, but is now they're cutting back on it after they found that it was causing this. You get this like stocking glove paresthesia, polyneuropathy starting in your lower limbs, ascending to your upper limbs. More affecting your distal groups in the proximal. This was independent of the toxicity of the organophosphates, so it was more related to which drug was causing it. And in the severe cases, uppermost neuron symptoms can be permanent, and they can have neurobehavioral deficits in the long term, similarly akin to like Parkinsonism. Our sympathomimetics, it's our stimulants essentially. Again, there's just a bit of a table as to where we get them from. A lot of the times we're seeing it as more our illicit drugs. The cocaine we're seeing fairly often. Duramine is a potential now that a lot of people are on these sort of weight loss drugs, so just think about it. But it's in anything, nasal decongestants, Sudafed, and many things. But typically you get this mydriasis, the agitation, tachycardia is your main thing, hypertension, and the sweating. Can look very similar to your anticholinergic, but I think with the anticholinergics, they don't sweat as much, whereas with the sympathomimetics, they're generally quite wet and sweating profusely. There's a high mortality risk if you're having a temperature that's staying above 39, despite your intervention risk, or morbidity and mortality. If you're having signs of coma, shock, or your temperature's persisting above 39 with an acute kidney injury. Generally, it's again supportive management. If you treat the agitation, you treat the hypertension, you use benzos for the seizures and the agitation. And for this one, we need to think about the secondary complications from the tachycardia, from the increased blood pressures. They can get some intracranial hemorrhages. You can get a myocardial infarction, which you manage as per the normal STEMI protocol. There's an endocarditis, but this is more, again, intravenous drug user history rather than for the toxidrome itself, and then aortic dissection. So just think about it in your background, screen for it clinically, and then if you do find any signs, then just screen for it with imaging investigations. So the activated charcoal can be quite good for this if you give it early enough. Benzos are our first choice for the sedatives and sedations. You've got every 10 minutes IVI, and if that's not working, then we go to haloperidol. Manage the airway, avoiding sucks. There was another case, I think, sorry, with the organophosphate, you don't really want to be using sucks to intubate. You rather just use your rocuronium. With the organos, again, it can persist with the prolonged hyperkalemia. And again, with this patient as well, they might have a hyperkalemia as well. For the hypertension, again, benzos, you start as your first line, but then nitroglycerins or your hydralazine is going to be your IV routes. We're not going to give beta blockers because that actually just makes things worse with cocaine. For the temperature, rapid cooling. The bath is the most effective, but the most impractical in emergency units because then you can't do anything else. So rapid cooling, get a fan on. If you have an aircon, put it on the coldest, make sure it's spraying right onto the patient. Get a misters or sprays that you can put onto the patient, ice packs into the neck, the axilla, and the groin. What you can do otherwise is you can just take a bed sheet, you can wet it and throw it onto the patients, but that you just need to be replacing. And then for the more extreme cases, there's lavages that you can do. You can put in a catheter and flush with cold saline into the bladder, or you can do rectal lavages as well. This is for your severe patients, temperatures above 41. But then if they're still staying there despite your interventions, intubate them, use your depolarizing agents, and that can try and help calm down the fever as well. Activated charcoal. The timing is really important for this. Generally, we can give it to most things. I'll chat next slide about what's not, but it's essentially your alcohols, your heavy metals that aren't really taken up by activated charcoal. If the airway is protected and the patient is awake and alert, there's no harm or downside in giving it if they're able to drink it themselves because you're not worried about the airway. Generally give them 50 grams mixed with water, but the best benefit is given within the first hour, potentially up to 2 hours if the drugs that's been taken delay their emptying of the stomach. Gastric lavage, we don't really do anymore. They found that the activated charcoal in the first hour is just as beneficial. You can consider if you know that the patient took a lethal dose of a drug within an hour and you think that you can try and get out some of the medications, but just put it in a nasogastric tube, see what comes out, and then put in your activated charcoal after that. The activated charcoal, there's other regimes that you give, and this is specifically for your high-risk drugs or extended release drugs. You give the same dose 4 hourly. So here's the things that are. It's generally our anti-epileptic drugs, aspirins, paracetamols, your illicit drugs as well. The ones not taken nicely is your alcohols and your heavy metals. So yeah, you can consider the high multi-dose charcoal once the patient's in the ward for the extended release or anything that's high risk. Then we can consider whole bowel irrigation. It's pretty much essentially giving a patient a laxative to try and pass everything that's in their stomach. This is for something that's not really well absorbed by activated charcoal. We give them a polyethylene glycol solution via NGT, or if they're awake and alert, tolerating a PO, give them 1 to 2 liters per hour. For adolescents, 1 liter per hour, and children less than 6, half a liter an hour. And we do this until the fluid coming out of the rectum is clear. This is for, again, your extended release drugs not absorbed, or if there's a concern for basal formation or body packing, which I don't think we see too much. That's more for if there's like drug mules or drug packing in the body. Contraindications to the bowel irrigation is obviously if there's any shock or gastrointestinal hemorrhage, uncontrolled vomiting or diarrhea, or if there's any ileus or bowel pathology. And then with the drugs, so we've treated it, we've managed it, we've tried to remove it. You can just think about then if nothing's working and they're still at the end of everything, having symptoms, you can think about enhancing the elimination. So there's hemodialysis, there's hemoperfusion, urinary alkalization for specific things. But just to think, it's not really going to be for the emergency setting, it's just something to think about. So this is where we get to the flumazenol question. The risk versus benefits. So some of the emergency paramedics and frontline people are saying they don't like to use it. They're saying it lowers the seizure threshold. If there's any co-ingestions, obviously it's contraindicated. And if it was just an oral ingestion of an isolated benzodiazepine, the morbidity and mortality can be potentially low. You're not having to chew many patients for it. Resedation is likely if we give it. And if the airway is compromised, there's potentially something else other than benzos. And they're saying that intubating the patients to manage rather than giving the flumazenol can potentially be better. However, the other side of it is that it can help us to prevent intubating patients. Even if there was seizures that they found, they didn't find many adverse effects linked to that. They didn't find that those adverse effects from giving the flumazenol causing significant morbidity. So we don't see it from the other side. So this will generate a question to you guys that do use it. Are you seeing the seizures coming through? Are you seeing any other adverse effects, or very happy with it?
Well, I haven't used it quite a lot. I've got only one patient, and I haven't seen seizures either. Yeah, I think not.
I think the ones we've used it, we haven't seen brilliant effect.
I've seen it 2 weeks ago. Patient from
Yeah.
So I think look, this is just a kind of statistically based on the waste, obviously, and it also depends how much you're giving, isn't it?
Yeah.
Sometimes the patient actually responds very well, and I think probably more advocated for elderly patients, because sometimes you don't know when do they actually wake up.
Yeah.
And unless somebody got underlying epileptic or underlying history of seizures, then something.
Right. So I just used a variety of places. If you want formal references, I can provide them. But also my handbook of emergency medicine, the toxicology book, up to date, looking at trying to find the most evidence for all of the toxidromes, EM guidance and our South African guidance, and then life in the fostering for some of the toxidromes. This is the Africa Institute of Emergency Medicine. They create this little flipper card, which is actually very helpful for the emergency room. It's got a whole bunch of useful information, and they've just summarized the common toxidromes on the back as one of the charts, but they go through anything from airway management, intubating, adrenaline infusions. So if you would like, they do sell them on the website. I don't think it's very expensive, but it can be a nice little tool to have in the emergency room. And thanks very much for listening. Thanks for organizing.
Thank you so much. I feel like actually, I don't know whether you should be consulting me or I should be consulting you. Because clearly, I think you know what you're talking about. I think probably you should be one of the experts in this topic actually, because I enjoyed it. Honestly speaking, one of the few presented that you actually love it, and because you just learn quite a lot. We thought we always, as a specialist, we think we know a lot, but the truth is that no. I think our minds are everywhere. So I think this is quite a very good presentation. And I think you highlight every small key things about it. And I think those who are online, if we miss something, maybe perhaps it's important to go back to podcasts and also try to replay it. And we would like people that are online, perhaps to also subscribe to the YouTube so that you can get the update automatically. So my biggest question with organophosphate, I think we're in Midstream, we're quite privileged that we're not seeing quite a lot. But in rural area, we're quite seeing quite a lot. And your opinion, do you think all those organophosphates still need atropine? When do you actually start atropine those patients? Who do we admit? Who do we tubes?
Yeah, so this is a bit of a tricky one, especially now with these delayed onsets that we're seeing. So we've had a few with colleagues at Brits where the patient was managed and fine, and then as they're about to go to the ward after about 6 to 8 hours, then the bronchoria and the bronchospasm started. So if there is a concern for organophosphates, I think it would probably be best if somebody's willing to admit for observations. I'm not sure this is where ideally a short stay ward would be great as a bit of otherwise just an admission for a ward for observation overnight.
Not the ward.
Sorry,
not the ward.
Yeah.
Yes, you know how it goes in the wards.
I think
every OD needs to be in my care for better observation. The next day they're fine, they can go to the ward.
because sometimes we think that actually they look very well in the high care or ICU or in the ward, But then you find that they go to bath, then they have cardiac arrest or respiratory arrest.
2 o'clock in the morning.
Exactly. So I think the reason.
2 o'clock is your time.
Okay, so the 2 o'clock. Why 2 o'clock?
I don't know.
Okay.
6 hours after they.
So now the 2 o'clock is related to their sympathetic tone in the bronchi.
Okay.
That's why most asthmatic will have wheezing from 2 o'clock. So now those patients, 2 o'clock, the bronchi actually becomes smaller. And that's why they get into arrest. That's why I think Dr. Engelbrecht is right. Those patients need to be given high care, but also perhaps before you send them to ward, have a look at the pseudocholesterol level.
Yeah.
Because if it's very low, don't send them to the ward because they're going to arrest there. Because it means they could, again, the symptom can reactivate, but also the fact that sometimes the atropine give them that false that they're actually better. And that it's got a short-acting life. And sooner or later, you found your patient's fine, out of blue, they collapse again, especially the young patients and the males. You know, they tend to be very strong, but when they fall very, very hard. So I think, yeah. Anybody online? Opinions? Questions?
This is one thing, the AfriTox, this, we have it also on the laptop, where it's a website that you subscribe to. So you can type in any keyword of the trade name or the ingredients, gives you all the toxicological information.
Guys, please subscribe to our LinkedIn channel and make sure that you're a subscriber, and also it's free of charge, and also on our YouTube, you know, so that at least we can give those details automatically. You can sign in with no problem. The program is really free of charge. And if possible, please, your colleague, we wanted medical doctors, everybody, if possible, to join, because it's really free education. We want to reduce complications for our patients, improve quality of our patient care, and you know, knowledge. And we also allowed to come, and you're invited to come and to present. If you want to present, you think you want to teach us about something, please communicate with us so that you can also present, because I believe education is the key. So please, let's work together. Obviously, yeah.
Just mention that the YouTube is called Sanocare Breath of Life.
Yeah. Breath of hope.
Oh, sorry. Breath of Life. Should
I
be
think
that.
we'll share with you guys. Why don't you just share the YouTube here so that at least they could actually see?
Yeah.
You go for internet, and then I go for Sanocare Breath of Hope. Oh yeah.
There you go.
Sorry.
Pops up on my phone.
Yes, there we go.
Don't you guys get a pop?
Yeah. Yeah, because you subscribe. Yeah, that's crazy. No, that's the
Yeah, but it's not. It's taking me to bigger videos.
No, but that's all the presentation.
Good morning.
Yeah.
Morning.
Good morning.
Yeah. So all the presentations are there. Yours will come in the next 2-3 hours.
Yeah, I can see. There we go.
There you go. Yeah, so that's really the YouTube channel. So I think just you need to obviously, I think, subscribe. You press subscription, then you put the email, and then you get all the pops up all the time whenever we have present. Then really strictly ready for us. And also maybe you can suggest us what topics you think you guys struggling with. And as I said, this is quite great presentation, so that at least we can cover all the hot topics, emergency medicine, the same thing as in pulmonology and others. And the idea is that I think you wanted to bridge the gap between emergency medicine physician, the specialist physician, the cardiologist, so that we don't have that, like, if somebody get angry with you because you haven't done 1, 2, 3, and the thing that you might not have seen or will not have the knowledge. So this is so that we can be able to work together very easily, and also with good understanding and good knowledge. I think knowledge is the only thing that can actually unite us and make sure that we actually speak the same language. So please join us. We are always available on Wednesday and Thursday, or online at 7 a.m. Yeah. Yeah.
And the link is the same.
The link is the same. Yeah. We have, So we have the same link, which is quite beautiful. Any other question, guys? Anybody having question to Van Staden?
The link in the chat. Is that the link to
or
the YouTube channel
yeah.
you want?